Hello, I am Vishal Peshattiwar. This talk is on percutaneous pedicle screw fixation. Well, to start, you need to have a good C-arm, a better C-arm technician, a good radiolucent table, and radiation protection equipment. There's no point in passing pedicle screws with a technician who is undertrained or with a C-arm that is not going to show you good quality images. Of course, there can be no more emphasis than giving on radiation protection equipment because you don't want to end up getting the side effects of radiation, some serious as cancer. Well, as you can see here, this is an image I borrowed from Dr. Vikas Gupte. You can pass a pedicle screw through a tube using the normal landmarks as we do in a classic open surgery. And how to pass that is very similar to an open surgery. However, if you were to pass a percutaneous screw, there are certain things that don't change. If you were to take a coronal plane cut through the spinal column, you have to be wary of these two structures while passing the screw. Those neural elements, the root and the dorsal root ganglion, are medial and inferior to the pedicle. Hence, an ideal placement of screw is somewhere in the center or the lateral aspect of the center and in the superior quadrant. Well, how do you achieve this? When you put your Jamshedi needle, that's the C-arm image of a surgery that has been done nearly 14 years ago. The entry point of the J needle is an optimal place that's between 2 o'clock and 3 o'clock position if it is on the right side of your screen. It should be in the outer and just above the center of these two cross sections. One question then asked is why not go a little more superior? If you go superior, you have to take in account this facet joint. The maximum adjacent level violations happened in the initial surgeries when the screws were put in more superior because the tulip went and sat on the adjacent facet joint, giving rise to adjacent level arthropathy. So it is either between 2 o'clock and 3 o'clock on the right hand side and in between 10 and 9 o'clock on the left hand side of a pedicle as shown here. Most of you have done vertebroplasty. Passing a percutaneous screw becomes easier if you have experience with vertebroplasty. If this is a sagittal plane of a vertebral column, that's an ideal trocar placement in a vertebroplasty. Similarly, if this is the point on the skin that you have marked, which is the lateral border of the pedicle, as you can see here, never start your entry here, because if you start at this point, the trajectory as you point it inwards will violate somewhere around the medial aspect of the pedicle and go more medially than you're comfortable with. So in such cases, it is better to go a little more lateral. About 2 to 3 centimeters lateral to the lateral aspect of the pedicle is an ideal entry point for a percutaneous pedicle screw to be passed. Once you have this, it gives you a wide and a very medialized screw, not what would happen if you were to start immediately at the lateral aspect of the pedicle. This 2 to 3 centimeters gives you an ideal placement of the screw as desired. Well, this is an CT image of a vertebra with 2 pedicle screws. This one is what you don't want because this is very, very close to the facet joint, isn't long enough, and does not give you good purchase. Whereas the one on the right-hand side of the screen is what you should be aiming at every single time you pass a screw. Another important aspect to note, to remain inside the canal of the pedicle and not violate the vertebral canal, you have to remember that while in the lateral plane, the needle has crossed the base of the pedicle and entered the vertebral body. In the AP plane, it should still be inside the pedicle. So while this is happening, what it means is when it has reached this aspect, it has already crossed beyond the pedicle. So now it's safe to tap it in more beyond this point because you're not entering the canal, but you are in the safe confines of the pedicle wall. If you understand this one fundamental concept, passing a pedicle screw is like a child's play. Well, a guide wire is then passed inside the hollow canal of the Jamshedi needle. You have to remember that a guide wire should never go beyond halfway mark, especially in osteoporotic and frail patients, because this is the single most dangerous equipment that you will be handling while doing investigative. Any migration of the guide wire in the abdominal cavity will have disastrous consequences. After that, you have to tap. This, like I said, is more than a decade and a half old image. We used to tap right just shy of the tip. Right now, we just go beyond the pedicle and come back. So this ensures that the guide wire does not travel back with the tap, and It gives the self-tapping screws a little more bite at the vertebral body. Well, this is a short video to show how this was done. This is again of the same case, I think more than a decade old. So you can see where my hemostat is. This is where my hemostat is. That's the lateral aspect of the pedicle. And I'm going about 2 centimeters lateral to it. You have to say, take a good incision. I felt the transverse process there. And that's the image where you can see that's the needle that's at the 2 and 3 o'clock position, and I pushed it in. It is already beyond the base of the pedicle here, but still in the middle aspect. Once that is confirmed, this wire has been passed. The wire is somewhere at halfway mark. We are now going to dilate serially over this so that the tap that goes in does not take a bite of the muscle. A serial dilator will then open up the muscles to let the tap go safely. Once the final dilator is in, and you are confirmed that it's sitting on the top of the pedicle, then you should use a tap. While you're doing it, it is always wise to stabilize the wire so that this wire does not migrate forward with the tap if there are some debris collected in the tap, or if the tap is going at an angle. So somebody has to stabilize this wire. Once you have tapped, this is too long. Nowadays, you can just go beyond the base of the pedicle. Then it has to be taken out. It's again wiser for somebody to protect this guide wire from coming out, as it will save you the time of having to reinsert it again. Once this is out, then it is the time to put a right size pre-measured screw inside. While you're putting in the screw, again, somebody needs to hold on to that wire so that it does not migrate in. Understand that the tulip of a screw is about 16 millimeters in most cases. So your incision has to be about 18 to 20 millimeters to let it go inside. Otherwise, it is going to carry the adhesive drape, as you can see in this case. To avoid this, it is better to take a little more generous incision and let the screw sit in at the base. This is the same procedure that you follow for the next level. Here I'm just tilting to get a better view of the pedicle, and these are the two screws that have been put in. It is always better to keep both the screws at the same level so that the rod that goes in subsequently can be inserted very well. You have to understand that the lateral orientation of all the vertebrae is different as per the level you want to approach. The best way to know what is the position of the vertebrae is to take a lateral image on the C-arm once the patient has been given a final position on the table, with a needle as a marker which is perpendicular to the floor. So you understand the relative position of the pedicles as compared to the vertical to the floor, and accordingly adjust your pedicle screws. In multiple levels, as in this case where we wanted to put in screws, as you can see, all of these are aligned on a straight line. If you have a screw that is off center, your rod which is straight is not going to negotiate that. You need to have all of these screws aligned straight so that you can give this secure fixation. Well, another easier way of doing it is to use navigation, where, as you can see here, you can have a 2D or a 3D navigation. I use an OAM based 3D navigation, which is probably the safest, where in 3 dimension, you can get a very optimal entry point. You can make your percute screw entry there. You can measure your screw accurately. As you can see, I can get an optimal length of the screw inside. I can also measure the exact thickness of the screw that I can pass, especially true in the dorsal lumbar junction in frail, thin Indian women. You can also track each screw as it has been put inside. Well, how does it happen? This is an OARM device which is doing a CT scan, a portable CT scanner of the patient on the table, which then gets loaded on the navigation. And instead of looking at the patient while operating, this is a real-time photo while we are operating, we look at the screen to see where our instruments are going. Each of this instrument is navigated and is calibrated to be recognized by the navigation. How does it go about? Well, this is a real-time imaging. This is what I'm doing, and this is what it is projected on the screen. The blue line here is that needle. I'm marking what would be the optimal entry point on the skin so that I know where to take a skin cut to go in. If a point to note is the amount, how lateral it has gone. So that is the marking there. I'll just play it again. So, sorry. So that's the second once the marking has been done. I'm putting in the needle. While I'm doing this, you can watch the virtual projection. This is going through the junction into the deep fascia. That's a plunge of the needle. Each of this action is reflected here. Now that I'm seated here, It is stable. I'm measuring the length, optimal length of the pedicle screw that will go in. And once I know I have measured that, I'll start tapping it in. As I tap it in, I can see this needle migrate real time inside. It is as simple as that. One of the biggest fears of putting a pedicle screw is the radiation exposure. As you can see here, there is absolutely no exposure. And I'm seeing, in fact, in 3 dimensions as to how safely and how correctly the screw is going. You can similarly track other instruments like your tap, as you can see here, and a finally placed screw real time as you're putting in, making this surgery extremely safe. Well, this is what the future is going to be. And this is something that has to be learned in real time. When you use a Jamshedi needle, it's better to use a mallet than to push in with your hand, because the chances of plunging when you're trying to push it with your hand, especially in osteoporotic bones, is high. A mallet gives you a measured push to put it inside. Always check with the C-arm when you're in doubt. It is better to have one extra shoe than to have a wrongly placed screw. Always beware of the guide wire. That's the most dangerous instrument that you use in uh, percutaneous screw placement. Always mark your landmarks on the skin so that you know where and what you're doing inside. Align your screws when you're doing it at multiple levels. Please take your time. There's nothing, again, like a fast surgery, but there are stupid surgeons who do fast surgeries. Thank you very much.